Before we get started, I'd like to ask everyone to please submit any questions via the question and answer capabilities in the GoToWebinar menu. We will do our very best to respond to your questions during the Q&A portion following the webinar. Also, we will be sending all attendees a link to the recorded version of this presentation once it's available. We are pleased to present how to use direct leverage for MU2 Success. Today, we will cover the nuts and bolts of direct secure messaging and how it is being leveraged by many types of healthcare providers to share transition of care information, a core requirement for MU2 attestation success. This webinar is brought to you by the Meditech Solution Group at Dell and DataMotion. To begin, I'd like to introduce you to our presenter, Andy Nieto. Andy is a health IT strategist at DataMotion. He's actively working with providers to help them attest to MU2 using direct and will share real-world experiences and tactics being employed to meet the transition of care requirements that direct enables. And I'll turn things over to Andy.
Thanks so much, Melissa. I appreciate it. And as Melissa said, I'm here to talk about direct and help you really understand it. So as you have questions, I think we're going to have quite a bit of time at the end. So feel free to get those questions in. As we go move forward, I'm going to start by going through what direct is and kind of talking a little bit about the history of healthcare IT. We're going to talk about the controls in place that run direct. We're going to talk about the ecosystem that direct is operating in, and then we're really going to talk about integrating with direct. We'll go over some of the challenges and successes that direct is facing right now, and we'll go through some best practices. And then we'll finish up talking about what the future really holds for direct secure messaging and going beyond meaningful use too. So let's start talking about the evolution of healthcare IT. If we look all the way back to 1971 and we think about when the first email was sent, this concept of sending and receiving messages via computer was really cool. And it wasn't too long after that the first real EHR was introduced. It's hard to believe that the first EHR was all the way back in 1972. And things kind of moved along without a lot of changes until 1996 when HIPAA came along. And we all know that HIPAA has become somewhat of a four-letter word in healthcare. And everyone tried to figure out, okay, what does it mean? And what does following HIPAA rules mean? And so we've been working on that for quite a while. Luckily, as things progressed, we saw EHR systems starting to be adopted. And then in 2003, we get the HIPAA security rule. And the HIPAA security rule talks a lot about how we protect the data, how we secure the data both at rest as well as when it's in motion. As we move forward down the timeline, we get the HITECH Act in 2009. The HITECH Act, as part of the American Recovery and Reinvestment Act, gives us a dramatic push to take the healthcare industry out of the clipboard mentality and into the 21st century. That's followed up not too long by the Stage 1 requirements, and then we get in final HIPAA omnibus rulings. These rulings gave us some real understandings about breach notification and the privacy rules. As we come full circle, we get into the rules for meaningful use 2, and we get into the first hospitals and providers attesting for meaningful use. So as we think about this, I want you to remember things like the security rule. I want you to remember that the final omnibus ruling, it expanded the security rule and the privacy rule and the breach notification rule, because these are important as to why direct is in our world today. Let's start by talking about the core measures that the different entities that have to attest have to meet. So eligible hospitals have 16 core measures that they have to meet. The two really applicable right now to direct secure messaging are Core Measure 6, which is the view, download, and transmit component for patients to see their medical record, and Core 12, which is the transition of care summaries. There are also menu objectives. One of those ones that's interesting is that we're actually seeing several that are using direct secure messaging to facilitate the electronic lab results to their ambulatory providers. Let's also talk for just a moment about the eligible ones. These are the EPs, or the also referred to as the ambulatory world. They have actually 17 core measures, and 3 of those measures are related to direct secure messaging. Again, view, download, transmit, summary of care for transition of care, and core measures for EPs includes the communication directly with the patient. But what is direct secure messaging? Direct secure messaging is a lot like email. It's actually built on an email foundation. This is an email, a direct secure messaging address, and it's bulls@direct.aclinic.org. Looks exactly like a email. What's different is it can only be sent to and received from another direct secure messaging account. So it begs the question, what is the difference? Since we're going to compare all three, traditional email, encrypted email, whatever mail encryption solution you might have, and direct secure messaging. Well, all three use a standard messaging format. It's a MIME compliant format, and basically that means it has a to field, a from field, a subject line, has the ability to move attachments, has a message body and things like that. All of them use the internet to deliver the message. Now this is where we start seeing differences. The encrypted mail and direct secure messaging both use an ability to encrypt and protect that message, meeting that security rule for HIPAA. In encrypted email, the encryption is proprietary to the vendor you use for that encrypted mail. In direct secure messaging, it's a standard encryption based upon PKI, and we're going to talk about that here in a little bit. Direct secure messaging also adds a component of identity validation. This is part of that privacy rule compliance. The identity validation comes in the certificate, the digital certificate that's associated with the sender and recipient. If you put this all together with the HISP, or Health Information Service Provider, who facilitates the communication for direct secure messaging, you get an end-to-end trust and liability. So if we were to look at this from a picture perspective, the sender can either use their EHR or their computer, sometimes even a mobile device, to send their messages via their HISP. That HISP exchanges those PKI certificates between the sending and receiving HISP. They use that digital certificate to encrypt the message so that the recipient can then receive a secured message. Let's talk about those digital certificates. There are three groups that are involved in creating the digital certificates. The RA, or Registration Authority, has the job of confirming you are who you say you are. Most of the HISPs, or Health Information Service Providers, comply with what we call Level of Assurance 3, which basically means we've not only said, yes, you are who you say you are, but we have looked at something like a government ID and gotten confirmation you really are who you say you are. The next group involved is the Certificate Authority, or CA. This is an entity that maintains a digital certificate and ensures the quality, accuracy, and independence of that digital certificate. Lastly, we've talked a number of times now about the Health Information Service Provider. This organization uses those certificates and manages those certificates for truly moving the messages from point A to point B. Now, a couple of times I've referred to PKI. PKI is a way of talking about public key infrastructure. The best way to describe this that I've found is to talk about a safety deposit box. The bank, as you know, the banker has one key. That's kind of like the public key. It's one that everyone's aware of, and it's the same for everyone. The private key, however, is unique to that safety deposit box. If you think about this from the direct standpoint, sender and receiver are identified because of their digital certificates. The sender then grabs the receiver's public key and encrypts the message using that encryption key. The message is then sent in a secure manner to the recipient, and the receiver's private key is used to decrypt that message. So what kinds of messages can we send with direct? Well, there really are types. There's provider to provider, and we see that a great deal in MU2. This is the ability to send from a hospital to a provider, or a generalist to a specialist, the transition of care or referral information. We also have provider to patient, which we see in the view, download, and transmit component. And this is the ability for a patient to forward the message from the hospital to another provider, requesting a second opinion, whatever it happens to be. The message flow works like this. sender, in this case Dr. Bob, is going to send from his Meditech system using DataMotion as the HISP to Dr. Susan, who's a cardiologist, who's using Cerner. So that integration with the EHR is a critical step. The HISPs confirm the identity validation, perform the encryption, and move the message. All of this represents the arc of liability. That is to say that because all the participants must adhere to the standards of HIPAA, must adhere to their business associate plans and everything else, there is a protection for breach notification. Now, as we start talking about things like HIPAA and breach notification, I've been asked a number of times, this direct thing's kind of complex. Who's really in charge? What is the health IT, which is basically an arm of the government that works directly with CMS and that have fingers in a number of different components of health, is kind of created direct. And then they awarded an exemplar grant to an independent organization called the Direct Trust. The Direct Trust really collaborates and focuses on creating the infrastructure and framework as well as the policies around how direct will work. The Direct Trust partnered with a company called ENAC to perform accreditation. The accreditation of HISPs, of CAs, and of RAs is used to ensure that all the messages that are moving from point A to point B are as clean as possible. So let's talk about the E-system. When we're talking about a Meditech hospital or an Epic hospital or something like that, we're really talking about this idea of going from an organization to a provider to an organization. And that's kind of represented in the dotted line boxes on this chart. But there are other participants to think about. One of those participants is registries. There are at least 2 public health registries that now use direct secure messaging for registration of immunizations, of public health information. There's even one that's actually talking about using direct for their syndromic surveillance. We also have government agencies, personal health records, and health information exchanges that are all using direct as a way of having that secure messaging. You see the relationship on this diagram of the registration authority and the certificate authority. This kind of shows you how they're all related. So let's focus in a little bit on just delivering from one place to another. You have the provider, related. I'm going to use our company, DataMotion Direct, as my example here. And one of the big questions is, how do we get it to integrate? I mean, that's really the spot, right? That's the question we have. There are a number of integration pathways that we can use. The primary one we're going to talk about today is an XD or XDR interface. This is an interface from the HISP to the EHR. Meditech, for example, uses an XDR interface. Some HISPs also can provide email client interface, a web portal, or different web services or API interfaces as well. One of the big challenges that we're seeing right now is there a provider directory? The answer is, well, sort of. We're getting there. One of the challenges we're facing, though, with provider directories is that multiple addresses will exist for every provider. Think about it. If you have a provider who is an ambulatory provider but also has permissions in the hospital, they're going to have a direct address in their EHR. They might have one in the HIE. They might have one in the hospital. And they might have one from an association. So knowing which is the primary address is really a challenge. The second challenge is that XD-based connections don't necessarily require a mailbox. Think of it, if your hospital has an XD connection, in this case, Meditech actually does use mailboxes, but some don't. So how would you put every provider under a domain? It's hard to manage that. There's no universal directory format. This is a huge challenge. One HISP, or Health Information Service Provider, might gather name and direct address, while another might gather name, address, phone number, specialist, specialty, NPI number, who knows? Since there's no standard format, how do you search on it? I point to history. And the history has shown that there is no directory of cell phones. There's no directory of fax numbers. There's no directory for email addresses. So it's not surprising then that we're having such a challenge in creating a provider directory. Now, hospital administrators and practice administrators always ask me, how do I know if the message that we got was delivered? And that's important to know. I want to know that it was delivered. The direct protocol actually has a component called the message disposition notification. The MDN lets us know if the message was dispatched. That means it's on its way. And if it was processed, which means the HISP has moved it on towards the recipient. So we meet that need. So let's talk big picture for a minute. Let's talk about what we see as the success for direct. Now, actually, over the last year or so, EHRs have been integrating direct secure messaging into their functionality. It's part of Meaningful Use 2. It's been important to be integrated. You all are on this call probably because you're in the attestation phase. You're interested in getting onboarded, getting those direct addresses functional, and finding a way to have the appropriate number of recipients so that you can send and receive messages, that you can leverage this to get the money for meaningful use. But where we will really see success will come when we're not just using it for transition of care, but it becomes the format or the standard for the curbside consult, where it becomes the de facto standard for sending and receiving any clinical information. Because, of course, we have met both the privacy rule, the security rule, and the breach notification rules by using direct secure messaging. Let's talk about some successes. There's some great successes going on right now. First is that 44 states have adopted direct. What this means is that in 44 states, the state agencies have recognized direct as a fundamental communication tool within their organization. We also have major growth on direct if we just look at it over the last year. You can see by the graphs the growth in addresses and the growth in overall messages. It's been pretty impressive. Another question, who's using it? How is direct being used? Well, here's just a small list of the organizations that use direct. Some of these might be like Baylor College of Medicine, upper right. They're using direct. U.S. Department of the U.S. military, right there in the top center. I can look down at the lower left and see companies like HIX New York. These are important organizations that facilitate communication in our world, and they're all using direct. There are some challenges. Let's talk about some of those challenges. The first one that hospital administrators seem to be having is, who has an address? I need to meet my attestation numbers, but I don't know who to send to. I can't find their addresses. We already talked about the challenges of a provider directory. It's somewhat like when the first fax machine came out. I was talking to a business machine salesperson once, and he said, I used to carry 2 fax machines every time I went to a customer, because if I sold them one, I had to sell them 2, so they had a sender and a recipient. The next challenge is the fact that in rural areas, the rates of adoption are much lower than they are in urban areas. It's a huge challenge when your referral partners are rural. Another challenge is provider awareness. It's interesting. I actually asked a provider the other day, what's your direct address? And he gave me his Gmail address. And I said, no, your direct secure messaging address. He actually didn't know what that was. CFOs who are focused on meaningful use are more aware of it than some of the providers. Another challenge we're seeing, more so in the ambulatory space than in the acute space, is the deployment of field-ready certified versions of their EHR. Since we rely on our EHR for that integration, for the meaningful use standards and everything else, when the ambulatory provider doesn't have a meaningful use version out there, they don't necessarily have direct. So how does a hospital that's going for attestation get messages to them? I'm going to talk about that in just a minute. The end result is ambulatory providers are just less likely to have direct capability or even the correct EHR version than their acute and hospital counterparts. So that's some negatives. Let's talk about some positives. I've mentioned already that 44 states have adopted. I can look at some large states like the state of Ohio that has fully implemented direct as a standard communication tool across the entire state. I can point to the Nebraska, Kansas, Missouri pilot program. This has actually been going for a year now because so many people in the Kansas City area, Topeka area move across all 3 states. There's a need to communicate. I also have some really cool statistics. We look at the attestations for Meaningful Use 2. We have nearly 2,000 eligible professionals and 78 hospitals have attested. Those numbers are a little lower than we all expected, but it's nice to see that some are able to do it. We're seeing successes. Another piece I think that's very important is that there are now 35 HISPs in the Transitional Trust Bundle. That means that there are 35 active health information service providers who can interoperate with each other. We also know that the Trust Bundle represents over 200 certified EHR products. This means that when you're trying to communicate with another person to meet that transition of care number, there's an increased likelihood that you're going to be able to do so. Some other statistics that I think are just staggering. There are 28,148 healthcare organizations using direct. There are over 428,000 direct addresses provisioned, and over 7.7 million messages have been sent. Pretty strong growth. I thought I would take a minute and talk about a couple of the hospital use cases that we've seen and the successes around them. The first use case to talk about is a health information network that needed to use direct, not just for communication, but as a way of integrating all of the features of this particular HIN. By leveraging direct, their built-in health provider directory, the record locator service, and their identity management tool, they've used direct to reduce redundancies and provide a single sign-on capability across a number of different solutions within the health HIN. Direct has become their fundamental communication tool across the entire network. Another use case I want to talk about is Cumberland Hospital. Cumberland Hospital had a very, very short window to get set up because they were going for the Q3 attestation period. Because they were in a number of different processes and working very quickly, they needed someone to jump on it very quickly. It was very impressive how things came together, and they were very able to just extremely quickly get live on a direct secure messaging platform. And now they interoperate not only with their providers, but they're an active leader in their local HIN, the East Tennessee Health Information Network. So I want to move on to best practices now. A couple of best practices that I think are very, very important. The first is I strongly recommend that you have a vision and plan for communicating within your community. This isn't just about having direct secure messaging. It's not about deploying a single tool. It's having a plan for how you're going to reach out to your entire community. The next recommendation I have is when you're looking at your transition of care events for attestation, aim high. If the goal is 10%, plan on hitting 20% because you're going to run into some obstacles down the road. Some of them may be as simple as the HISP isn't live for my largest referral partner, or their EHR is going through an upgrade, or something like that, and you want to hit your numbers. Leverage technology to make partnership relationships more sticky. What do I mean by this? Think about the cost of getting a good referral partner. This is especially important in urban areas where a provider has multiple choices. If you can make the relationship so easy because the transition of care documents go in and come out extremely quickly and extremely efficiently, the provider is more likely to use your hospital. I strongly suggest when you talk to the HISPs, when you're picking a HISP, ask them what their experience is in integration in healthcare. We've seen a number of HISPs in the market that, while technically accurate, they are performing direct secure messaging. Their experience in overall healthcare, in overall workflow, is very low. So as a long-term partner, they may not be the best choice for you. This next bullet should actually read, focus on the long-term monetary value to the hospital. Making those sticky relationships, making those the referral partners active and valued, increases the referral revenue to the hospital. And finally, look for ways to integrate at the community level. How are you going to reach out to your post-acute care, your rehabilitation centers, your long-term care facilities? How do you reach those, especially if they're not using an EHR? Does the HISP that you've partnered with have that ability to help you meet those community needs? Let's talk about how you pick a HISP. First question to ask is, are they accredited? Not every HISP in the market has actually been accredited by ENAC. The second question to ask is, do they have proven interoperability? It's completely okay to say, we're a Meditech hospital and eClinicalWorks is the #1 ambulatory EHR in our community. Have you ever communicated with them? Any problems? That's a question they should be able to answer very quickly. Third question, do they integrate with your EHR? Again, talking about a Meditech hospital, do they have the ability to meet the XDR requirements, and do they have a track record of success in connecting to Meditech? And lastly, what services do they offer to help you achieve your community goals? Not just your connectivity goals, but to help you actually become the leader in your community. I want to close part of what I'm talking about today by looking at what the future holds. Some of the things that we're seeing in the market really suggest that the direct will become the standard for healthcare communication, not only in EHRs, but in HIEs and in public health. We see a lot of increase in patient engagement, things like patient self-reporting, and the ability for patients to communicate for syndromic surveillance. There's already talk about product integration. Imagine if the blood sugar monitor or your blood pressure cuff can actually communicate to the provider what your current numbers are. One of the very interesting things I see on the market is this idea of electronic submission of medical documentation. ESMD actually is saying this is a way to digitally record, communicate, and submit electronically with no paper ever changing hands. Related to that is this idea of e-signing, this use of digital certificate as an identity. Now, if you recall, direct secure messaging requires a digital certificate. Imagine if that digital certificate was also the same certificate functional for you to sign off on prescriptions and to track that type of interaction. So I hope I've enlightened you a little bit about what direct secure messaging is, some of the pitfalls along the way for getting it integrated, and giving you some good advice to how to move forward. Now, as promised, we have a lot of time for question and answer, so I'm going to turn it back to Melissa.
Thanks, Andy. I think we're ready to take some questions from our attendees. If you want to submit a question, please do so using the question field in the GoToWebinar menu. Our first question for you, Andy, is what is the relationship between Dell and DataMotion?
That's a great question. Dell is a wonderful partner of ours, and I know I'm supposed to read something here. Dell has signed up to provide DataMotion direct services to their acute customers. They're a reseller of DataMotion services and solutions, and they're a great pathway to get great advice and great answers about how this whole integration system works.
Awesome. eClinicalWorks has given some providers with addresses like BobMD at ecwdirect.xxxx.xxx. Is this really direct?
The answer is it might be. If this was issued to you as a direct secure messaging account, then yes, it's very likely that that address, that unique address may be yours.
Okay, great. How are HISPs accredited?
HISPs are accredited through a set of criterion that was published by ENAC. The set of criterion is presented to a HISP, and the HISP first off signs a letter of agreement basically saying we will adhere to these standards. Standards not only of keeping direct functional and live, but standards around the protection of health information and PHI. Standards around how we will secure our data systems, our data centers. Standards around the infrastructure and the environment. And also a presentation of policies and procedures that we will adhere to. They're next audited by a special auditor trained in looking at not only the importance of the infrastructure and the functions, but also the policies and procedures and the ethical ability to deliver on direct secure messaging. After the audit and evaluation by ENAC, if their party is deemed worthy, they are issued an accreditation status.
Great. How often is XDR used in comparison to SMTP?
I don't know that I have any great statistics for you on it. What I can tell you is that 9 out of 10 of DataMotion's acute customers use XDR, and about 80% of DataMotion's ambulatory customers are using web APIs. SMTP accounts for maybe 5%, but that's just DataMotion. I can't speak to other HISPs, but it is an opportunity out there.
Okay, great. Can you elaborate on the XDR interface in more detail? Where can we download the WSDL and whether it is standardized or people may use some variations?
Okay, so that's 2 different components. So let's first talk about XDR. And the XDR standard is very similar in many ways to a VPN tunnel, a virtual private network tunnel between a sender and recipient. That usually requires the network engineer for the hospital or the system and the network engineer from DataMotion or the associated HISP to get together and set up the endpoints, confirm communication, and confirm the security protocols and the encryption between those 2 endpoints. Now, when we talk about a WSDL file, that is available from your HISP provider. If DataMotion is your HISP provider, I can certainly provide you that after the fact. We do have a WSDL available for the integration of web services for DataMotion. And if you can put your information into the chat window or into the questions, I'm sure that Melissa can get that to me after the call.
I certainly can. Is there some test HISP or some entity which may create a test account for us to test our implementation of Direct?
That's a great question. So there's a couple of places you can go. The first is the transport testing tool is a NIST tool. And the transport testing tool has the ability to both receive a message and send a message. The second place that you can go is to something like Microsoft Health Vault. Now, not all HISPs participate in Microsoft Health Vault, but that's certainly one place to go. And the last thing I can tell you is that DataMotion does provide test accounts as well, should you want to use DataMotion as a test environment.
Awesome. What kind of data can be sent using Direct?
As we talked about early on, the Direct protocol, as it's written, is very much like email. You can have attachments, you can have message body, conversation, anything you want. So from a protocol perspective, if it fits in an email, it likely will fit in direct secure messaging. Now it gets a little bit more complicated when you look at the EHR integration. The EHR may functionally only recognize certain things like the CCD, or in some cases a CCD and or an XML document or something like that. But from a technology perspective, Direct can move anything.
Great. Direct seems complicated. Where can I go for help?
It's a great question. If you're a Meditech hospital, I strongly encourage you to contact your Dell representative and ask them for help. They're equipped with a great deal of information, and they also have the ability to contact DataMotion, who is Dell's partner for HISP services, and they can get us on the phone. You can also go to directtrust.org. The directtrust.org site has a great deal of information about accreditation, about the status of different HISPs. And finally, if you go to directproject.org, you can actually see the S&I framework and the functional requirements for direct secure messaging. And finally, if you really just get stuck, my information's on the screen. Give me a call.
Awesome. Are you aware of any organizations which provide their hosted implementation of HISPs which we can use under our branding for our customers?
So the answer is a number of them. DataMotion certainly does. It's a great question to ask. If you're looking to use any kind of web portal or any type of branding, or it's very important to you that you use your own domain name, be sure that you ask that question of the HISP that you're talking to. Many can, many cannot. So it's just a matter of looking at it. DataMotion certainly does provide that information.
Thanks. Is a HISP always needed for sending or receiving a direct message?
The answer is yes. For a direct message to go, both sides have to have the ability to manage the certificate, perform, and integrate using the direct technology. I paused a little bit because there are a couple of EHRs that have built HISP functionality into their EHR. So while it is not a traditional HISP as a standalone entity, it is still HISP functionality. So yes, a HISP is required for the sending and receiving of direct secure messaging.
Okay. What is the role of a HISP in provider directory exchange?
You broke up just a little bit. Can you ask that question again?
Of course. What is the role of a HISP in provider directory exchange?
It's a great question. So when we talk about a HISP, that's usually where the mailbox or providers have their addresses onboarded. So first and foremost, the HISP facilitates the exchange of the certificates and the movement of the messages. But because they are the central point of communication between other HISPs, they become the repository for the information on the providers associated with them. So they have a role in sharing that information in some kind of federated way with the other HISPs. So they play a pretty significant role. It'll be very interesting to see as the Direct Trust and the Direct Project, and especially the work by the Office of the National Coordinator at coming up with a uniform provider directory standard, what comes out of that.
Okay. Can two peers connect via XDR bypassing HISP?
In theory, probably. But in functional, it wouldn't be direct secure messaging. It would be a secure secure communication pipe. The XDR pipe would only be the technology, if you will, the wire between the two. But the protocol to facilitate the communication between two sides wouldn't be there. A HISP would be required for that, for the actual message delivery and negotiation. The other component of that is that if you have two facilities connected via XDR, that doesn't necessarily meet the exchange standards for MU2. You'd have to really, really evaluate the goal of that kind of connection. The other thing to think about is, if you're, one of the reasons Direct was created is to somewhat remove that burden of multiple point-to-point communication, multiple point-to-point interfaces. That's one of the challenges that, I think about a hospital having to, create a static connection to every single one of their providers. It would be financially undoable. Whereas Direct, by having one connection to a HISP, allows you to communicate to any other HISP that's certified and to all of those providers underneath them.
If an organization uses a different HISP, can I send a direct message to a provider at that organization?
Absolutely, and that's really one of the fundamental backbones of direct, is that there is no independent network. It's not like some of the original e-prescribe networks. You had to ask, which network are you on? Are you on RX Trust? Are you on, which one are you on? No, it's kind of ubiquitous. As long as there's a HISP involved and that HISP is accredited or part of the trust bundle and those HISPs have relationships, then the message communicates from point A to point B.
Can I get the provider directories of organizations that don't use the same HISP as my organization?
The answer is maybe. Again, when we're talking about provider directories, because there's not a universal standard between both ends, and because that standard between both ends may not fully align, you might be able to get a directory, you might not. As things progress, I think that we'll see more standardization and more exchange, especially more federated exchange. I know that there are a number of organizations and the Office of the National Coordinator that are really working on that kind of universal standard. So I believe that the answer is going to be more to the yes side the further down the road we get. Right now, the answer would be maybe, depending upon what opportunities we have.
Okay. Is DataMotion a private company providing commercial solutions, or is it affiliated with HHS, CMS, or other government organization?
DataMotion is a private organization. We've been in business for about 15 years providing direct secure messaging. We're privately held, based in Florham Park, New Jersey, and we have our development environment and several other locations and a number of remote employees as well. So we're a private organization. But we do attend meetings from HHS, from ONC, and from CMS, and we are active participant in the work groups for all of those organizations so that we can stay up to date with all the technologies and all of the advancements so we can always be a positive and supporting provider. Great.
If we choose a HISP, what should the domain be for our organization's direct addresses?
That's a great question. So there is no right or wrong domain. DataMotion and a number of other HISPs, not just Data, but a number of other HISPs, provide the ability for you to use your own subdomain. So if Acme Hospital is the name of your hospital, you could use, for example, direct.acmehospital.org as your domain for direct. As a previous question was, they had received a unique eClinical domain where eClinical was providing the direct domain, and that's okay as well. So there's no right or wrong answer, but it is a decision point when you're deciding what HISP to go with. If it's important to you that you use your own domain, then that needs to be a question you ask your HISP. Can we use our own domain?
Great. I'm going to pause a second and ask if there are any more questions before we wrap up. The question mode in the GoToWebinar menu on your screen. Before we wrap, Andy, is there anything else you'd like to add?
Just that I would encourage you to look at direct as a really powerful secure communication tool, and a tool that will continue to evolve to be really fundamental to your program. To go to your Dell representatives if you have questions about direct, and if you don't have a relationship with Dell, certainly can also reach out to DataMotion.
Great. Well, thank you all for your questions today. If we didn't answer your question in today's session, or you have additional questions, please reach out via email. You will also receive an email with a link to the recording of today's webinar. Thank you all for attending, and have a wonderful day.